Good morning, everyone. Uh, Today I'll be talking on a topic from the bacteriology, that is streptococcal infections and its complications. I have a case scenario related to this streptococci. It's a 12-year-old child presented to pediatrician complaining of dry, scratchy throat, pain. She is complaining of throat pain with running nose and dry cough. And present complaint started as hoarseness of voice few days back without fever. Body temperature is being fluctuated between normal to slight high. On physical examination, posterior pharyngeal wall is edematous and red with yellowish exudate on the tonsils. Multiple enlarged tender cervical lymph nodes were observed and no abnormality detected in other systems of the body. And throat swab and gram staining examination reveals gram-positive cocci in long chains with plenty of pus cells. So, what is your probable diagnosis and common causative agent for this, and virulence factors and toxins and pathogenesis and this bacteria, and we have to know the lab diagnosis and treatment of this particular disease. This for the sore throat or the many, one is Arachnobacterium hemolyticum, which is usually rare cause and commonly seen among the teenagers and young adults. And next one is Corynebacterium diphtheriae, which is commonly followed by travel and also among the non-vaccinated people, and also the vaccine failure cases we can see this. And Mycobacterium pneumoniae is another one which is common among the teenagers and young adults. And Neisseria meningitidis, usually it's in a commensal in the oropharyngeal region and followed by the child abuse. It may cause for sore throat. And next one is, which is not the least, but that's the first one to be considered, the Streptococcus pyogenes. That's the most common bacterial cause for sore throat. Viruses or adenoviruses, Epstein-Barr virus, rhinovirus and coronavirus, and cytomegalovirus and influenza virus, all also these causes for sore throat. This streptococci, which is considered as a common causative agent from the bacteria to produce streptococci, it has to be classified based on oxygen requirement as aerobes and facultative anaerobes, and also the obligate anaerobes. The best example for this obligate anaerobe is Streptococci, which is commonly associated with some kind of anaerobic infections, especially on the face in the form of acne. So that will be discussed under the non-sporing anaerobic bacteria. That's a separate chapter is there that will be discussed. And again, now if you go to this classification of streptococci, depending on these hemolytic properties of streptococci on blood agar, they can be considered as beta hemolytic streptococci, where you can see the complete zone of hemolysis when they are growing on the blood agar medium. Alpha hemolysis or alpha hemolytic streptococci, where you can see the growth as green colored discoloration around the colonies on blood agar. And next one is gamma hemolytic streptococci, where you can't see any kind of hemolytic property around the colonies when they are growing on the blood agar. So based on this hemolytic property on the blood agar, streptococci can be classified as alpha hemolytic, beta hemolytic and gamma hemolytic streptococci. Again, beta hemolytic streptococci, based on the carbohydrate antigen present on their cell wall, divided into 21 serogroups, and these serogroups are designated as Lancefield serogroups and designated from A to V except I and J. So A, B, C, D like that serogroups are there. but I and J are not to be seen. And again, this groups, Landsfield groups, based on the protein antigen present on the cell wall, it can be divided into 100 serotypes, and this serotyping is known as Griffith typing. So what we have to understand is the serogrouping of beta hemolytic streptococci can be done based on the carbohydrate moiety present on the cell wall, whereas the Griffith typing is being done, that is serotyping is done based on the protein antigen present on their cell wall. Yeah. What are the medically important streptococci among the many streptococci available? One is Streptococcus pyogenes, which belongs to the group A streptococci and produces beta hemolysis, and associated with upper respiratory tract infections and also the skin infections like pyoderma. And also these complications with these Streptococcus pyogenes are seen in the form of rheumatic heart disease and also the glomerulonephritis or nephrotic syndrome. And next one is the Streptococcus agalactiae, which belongs to the group B streptococci, but again produces beta hemolysis and commonly associated with neonatal meningitis, the meningitis in the newborn or early newborn, and septicemia, another problem with the Streptococcus agalactiae. And Streptococcus equisimilus, it belongs to group C and also produces beta hemolysis and associated with pharyngitis and also the endocarditis. And the next important group is viridans group, otherwise called alpha hemolytic streptococcal group, alpha hemolytic streptococcus group. And these are not being classified under this particular beta hemolytic property, and usually they produce the alpha hemolysis and commonly associated with the infective endocarditis among the people who are having comorbidities or the people who are on prosthetic heart devices. And the bacteria also sometimes possible with this, and the best examples for this are Streptococcus mutans and Streptococcus sanguineus, which are associated with dental caries. And last one is enterococcal species, which belongs to the group D according to Landsfield grouping and produces non-hemolytic colonies and blood agar, otherwise called gamma hemolysis, and they are associated with nosocomial infections, especially in the form of urinary tract infections among the catheterized individuals and also the endocarditis. Main culprit producing the sore throat is the Streptococcus pyogenes, as I mentioned already, which belongs to group A streptococci with beta hemolysis. So that is the commonest organism causing for the sore throat among the people. And here this is the commonest pathogen from group A streptococci, and which is seen in the form of long chains. The cocci arranged in long chains, you can see here the cocci arranged in long chains, and they are aerobes and facultative anaerobes also. They can grow wide range of temperature like 22 degrees centigrade to 42 degrees centigrade, but optimum temperature is 37. Like any other bacteria, the optimum temperature is 37 degrees centigrade. And if you see their growth requirements, they are bit fastidious organisms, means they can't grow on nutrient agar. They can't grow on nutrient agar. They grow on the medium like enriched media, like on blood agar. Blood agar only the best medium to grow, or any other enriched substance should be present to grow this particular bacteria. And they are catalase negative. This is genus specific nature. None of the streptococci are positive for catalase test, and they are insoluble in the 10% bile. These are the general features of these Streptococcus pyogenes. The virulence factors and their activity in producing disease of this particular Streptococcus pyogenes. First one is M protein, which is a major virulence protein and responsible for inhibition of phagocytosis. As you all know that, followed by the entry of any foreign cell into the body, the first cell which is responsible for defense mechanism is phagocytic cell. This phagocytic cell, by means of phagocytosis, will try to eliminate the antigens which entered the body. So this M protein, which is present on the cell wall of this bacteria, will inhibit this phagocytosis and thereby allow the microorganism to survive in the body. And these M proteins appears as hair-like projections on the cell surface, and based on this M protein, more than 80 different serotypes have been identified, like serotype 1, serotype 2, and serotype like that, up to 80, more than 80 serotypes are identified from the Streptococcus pyogenes. And this M protein is immunogenic, and the antibody produced is protective in nature. That is one virulent antigen. And number 2 is streptolysin O. This is a toxin. It's a toxin produced by this particular bacterium which lies the RBCs, and the activity destroyed by oxygen, and it's mainly immunogenic. The antibodies which are formed are known as anti-streptolysin O antibodies. These are more useful for the recent diagnosis of this particular bacterial infection. Another important toxin produced by this bacteria, of course, it's not much related to their pathogenesis, that is streptolysin S, and which destroys the RBCs, and this is oxygen stable, whereas that's streptolysin O is oxygen labile, but this is oxygen stable. It's non-immunogenic, so no antibodies are formed against this streptolysin S. Enzyme is streptokinase. Another virulence factor, and enzyme is streptokinase, which hydrolyze. It's an hydrolytic enzyme, and is responsible for spread of the lesions, the spreading of the lesions in the tissues. And next enzyme is DNase, otherwise known as streptodornase, which is immunogenic, and the antibodies produced against this DNase enzymes can be used to diagnose the recent infection, especially the immune complex mediated infections are diagnosed by using these streptodornase or DNase antibodies. Next one is hyaluronidase. Hyaluronidase is considered as a self-destructive enzyme, and this hyaluronidase is responsible for the destruction of hyaluronic acid. This hyaluronic acid is present hyaluronic acid is an intracellular substance, and so this hyaluronidase acts on the intracellular substance of the infected tissues and responsible for spread of the lesions, spread of the infection. But why I called it as self-destructive, the reason is this hyaluronidase acts on the capsule of this bacterium. This capsule is made up of hyaluronic acid, and so the hyaluronic acid, so it causes for destruction of this particular bacteria. Next, most important toxins are streptococcal pyrogenic exotoxins, simply called as SPE. It's this streptococcal pyrogenic exotoxins are 3 types are there. One is A, B, and C. And these streptococcal antigens mainly considered as super antigens. Why they are called super antigens? These particular toxins are not subjected to the T lymphocytes through the TCR, to the T cell receptor. Usually any antigen will be present to the T lymphocyte through the T cell receptors. But here in this particular case, they will be present on from the lateral side of not through the TCR. Laterally they will be presented through the MHC class 2 molecules on the APC and responsible for release of large number of cytokines like interleukin and tumor necrosis factor, which results in multi-system organ failure known as toxic shock like syndrome, or sometimes it's also known as cytokine storm. This cytokine storm we heard in many areas of infections. Even COVID-19 also produces cytokine storm. Wherever the antigen presented to the T lymphocytes laterally, not through the T cell receptor, then that is known as, that kind of antigens are known as super antigens, and super antigens are responsible for cytokine storm. So dengue virus also produces this kind of cytokine storm because it also acts as super antigen, and even COVID-19 virus also responsible for cytokine storm. For certain purposes, that is it. The mechanism of this streptokinase is it converts the plasminogen to plasmin and breaks, but this streptokinase breaks down the fibrin clots around the infected site. This is how it facilitates the spread of the infection. But this streptokinase can be used in the treatment of pulmonary thromboembolism and also myocardial infarction, where the clots are present. So these clots in this pulmonary area are in lungs or in cardiac vessels are broken down by using this streptokinase enzyme. And also the antibodies against the streptokinase are responsible for retrospective diagnosis of streptococcal infections, or old infections of streptococcal infections are identified by these antibodies. Next one is streptodornase. The mechanism of action is it liquefies the thick pus by depolymerization of free DNA released from the pus cells or necrotic cells. So this particular property is used in the treatment of empyema. So in the empyema, that is the pus collection in the pleural cavity, if it is thick in nature, it's difficult to drain by intracostal drainage tube. So what we do is we introduce the streptodornase enzyme into the pleural cavity, and then the thick pus will be liquefied and then it will be drained easily. And again, the antibodies produced against streptodornase are useful for the retrospective diagnosis of streptococcal infections, especially in the glomerular nephritis or nephrotic syndrome secondary to pyoderma. Aspects of the streptococcus pyogenes, the source of infection is the aerosols from sore throat, secretions and skin lesions, and it can be transmitted by means of either inhalation of aerosols or droplets and undroplets, and direct contact from the contaminated fomites. This is another mode of transmission of this particular bacterial infections. Outbreaks are common in the boarding schools and army camps where the crowding will be more. Sore throat is common among the 5 to 15 years age group, rare in toddlers and less than 3 years age group. And incubation period is less than 5 days most of the times, and it's presented in the form of sudden onset of fever with more than 101 Fahrenheit and higher sometimes, and red will be throat will be very sore and red in color, with sometimes you can see the white patches. See here, the white patches also present here. The white patches are seen, and the people will suffer with headache and chills, loss of appetite or poor appetite will be present, and cervical lymphadenopathy, the enlargement of the or painful enlargement of lymph nodes of neck are seen, and there will be a lot of difficulty in swallowing. That's because of severe inflammation of the throat and its appendages. It will be difficult to eat or deglute something. Soft tissue infections produced by Streptococcus pyogenes, the most common thing is cellulitis. Here you can see the cellulitis of the face on the person, and elderly person, and where the skin and subcutaneous tissues are commonly involved with the severe edema and redness and also pain on touch. Fever also will be present in this case of cellulitis. So this is another important spreading type of cellulitis. You can see this is a how big the spreading. Here you can see this is the entire area of cellulitis. And next one is erysipelas, is another important skin infection, which is acute and spreading type of lesion with the involvement of superficial lymphatics and produces lymphangitis. See here, if you see in this photograph, the lesion is here actually, but if you see the hand, the entire hand, see the glistening and redness of this entire hand, how the lesion has been spread. So this is how this erysipelas will spread with the involvement of local lymphatics, and the area involved shows the swollen and red and indurated area with tenderness, and commonly seen in elderly people. This is commonly seen in elderly people. Cellulitis may be seen in adults as well as anyone, all age groups. In all age groups it produces the cellulitis. But this one is very common. Erysipelas is very common in the elderly people. Pyoderma, this is commonly seen among the children. This is commonly seen among the children and mid, adolescents also. Here also the lesions are superficial and localized lesions, but discrete in nature. Discrete in nature. See here the discrete lesions here all over the thing, and commonly seen on the face and legs of the involved persons, and it begins as a red papule. It begins as red papule, then it will be converted into the vesicles, and finally becomes pustules. Pustule means the lesion filled with pus, and finally they ruptures. See here how they are ruptured. This is all the ruptured lesions and ruptures, and finally gives like an appearance like a honeycomb like appearance. These crusts also called honeycomb like crusts are seen. The lesions are painless and no fever. The lesions are painless and no fever because of non-involvement of lymphatics, and lesions are superficial, so you cannot see any kind of pain here. Presentation of the streptococci we can see in the wounds. We have the case scenario here. A 55-year-old man presented with left foot pain and swelling over 2 weeks. He is a known diabetic since 12 years. On examination, a gangrenous lateral lateral two toes is present with discharging pus, along with heart, that is warmth, and crepitus also present on the affected area. The wound debridement was done and sent to the microbiology lab for processing. And gram stain again shows the gram positive cocci in chains. Culture shows pinpoint colonies and blood agar. And antibiotic sensitivity test shows the sensitivity to penicillin, azithromycin, and clindamycin. So this is the case scenario for the Streptococcus pyogenes, to say that they are also responsible for wound infections in the form of gangrene, in the form of gas producing lesions. The crepitus you can see, that means if you are able to see the crepitus in the lesions, that means a lot of gas is associated with that particular gangrenous area, just like Clostridium welchii, which also responsible for the mainly responsible for the gas gangrene. Like that, these organisms also responsible for gangrenous lesions. These are commonly the deep-seated lesions. These gangrenous lesions are deep-seated lesions. And the most important deep and soft tissue lesions produced by Streptococcus pyogenes is necrotizing fasciitis, otherwise known as flesh-eating disease, or hemolytic streptococcal gangrene. This is more common among the people who met with road traffic accidents due to the rollover of the main vehicle tires on the muscle mass of the body. And here the lesions are mainly due to, our clinical manifestations are mainly due to the SPEs, that is streptococcal pyrogenic exotoxins are responsible for these lesions, and these toxins are very effective and produces this kind of lesions. See the how the lesions are seen, which are this big bubbles like with gas formation and all. You can see the lesions, and the severe pain is seen, which are rapidly increasing swellings, and fever and redness is present. Later the lesions becomes dusky like this. They becomes dusky like this, and anesthetized due to the nerve damage. All these kind of manifestations finally leads to the necrosis of the entire involved area. Clinical presentation of streptococcal infections is ASPES, is scarlet fever produced again by these streptococcal pyrogenic exotoxins of the Streptococcus pyogenes, very common among the children less than 10 years age group. Nowadays, because of the invention of large number of antibiotics, the scarlet fever cases are a bit rare, but it's presented with fever, pharyngitis, and a characteristic rash with discomation, and if you try to touch it, you will get a feel like sandpaper like feel. You can feel like in a sandpaper, a kind of rash is seen on the body, and the tongue appears like with a kind of lesion, a kind of appearance which is nothing but like a strawberry appearance. This is known as strawberry tongue. This is because of this toxin activity. And rash in the skin folds also seen. See this rash in the skin folds, and this rash in skin folds are considered as Pastias lines. The Pastias lines, strawberry tongue, and sand, the paper feel appearance, all are the features of scarlet fever produced by Streptococcus pyogenes in children. This mainly produced by the M types 1, 2, 3. I have already mentioned, no, there are more than 80 M serotypes are present. That comes under Griffith typing, right? So this M serotypes 1, 2, 3 are mainly produces toxic shock syndrome toxin. This toxin is responsible for acute fulminating disease with respiratory distress and renal failure, and flu-like symptoms are seen among the individuals who are suffering with this TSS, like fever, chills, muscle pains, dizziness, vomiting and confusion, and a characteristic rash is produced, that is a flat red rash present on the flat. See, this is the flat and the red rash present on the body, and is associated with heavy mortality, that is around 20 to 30%. And the treatment of choice is penicillin with clindamycin is best. Of course, this toxin can't be what we call neutralized by the penicillin G or clindamycin, but further production of this toxin will be reduced by introduction of antibiotics timely. Complications of this streptococcal infection, Streptococcus pyogenes, are puerperal sepsis and lymphangitis in the genital area, and abscess are seen in the internal organs of the body, like brain abscess, lung abscess, liver abscess, and kidney abscess, also produced by the Streptococcus pyogenes. And common complications followed by the streptococcal sore throat or otitis media, sinusitis and mastoiditis, and quinsy, that is unilateral peritonsillar abscess. Unilateral peritonsillar abscess is known as quinsy. That is another important complication. And meningitis followed with respiratory tract infection, and bacteremia, and post-viral pneumonia. Any viral infection, any viral infection later as after 1 week or days, if you won't give the proper prophylactic antibiotics, then it may leads to pneumonia. And the commonest bacteria associated with post-viral pneumonia is Streptococcus pyogenes after the Staphylococcus aureus. This antigenic cross reactions between the contents of the cell wall and also the cytoplasm of the bacteria with the many antigens of the human body results in some immune complex mediated diseases. So the capsule cell wall, see the capsule cell wall, the protein MT are proteins on the cell wall, and the carbohydrate antigen on the cell wall, and mucopeptide and the cytoplasmic membrane and lipoteichic acid present in the cell wall are having cross reactivity with the synovial membrane of the human body, and also the valvular tissues of the body, and the cardiac cells of the body, and also the myocardium cells of the body. And also these antigens will cross react with vascular intima of the blood vessels, and also the skin, and also the kidney cells. So when this is happening, the antibodies, these acts as an antigens. So when it is exposed to the immune system of the host, and they produces their concerned antibodies, and these antibodies will recognize all these antigens are their counterparts and react with this antigens will react with these antibodies, antigens results in antigen antibody complexes, and these complexes will initiate the third type 3 hypersensitivity reaction, and results in damage to the involved tissues. I hope you understand the complexity here. So the various antigenic components of the bacteria will have the antigenically similarities with various components of the human body, like synovial membrane, cardiac muscles, skin, and kidney cells. So the antibodies which are produced against the bacterial components will react with the synovial membrane, cardiac cells, and valvular tissues of the heart, and also the skin cells and the kidney cells, and as their counterparts like antigens, and produces antigen antibody complexes and initiates type 3 hypersensitivity reactions. These immune complex mediated diseases may result in the form of two important diseases. One is glomerulonephritis and also the nephrotic syndrome and acute rheumatic fever. So 10 days later of the skin infections, mainly the skin infections, pyoderma and especially pyoderma are mainly responsible for glomerulonephritis unless you treat them properly. So it results in kidney dysfunction. This nephrotic syndrome or glomerulonephritis results in kidney dysfunction and manifested in the form of swollen or pedal edema, otherwise called swollen ankles, eyelid edema also present, hypertension will be there, and blood and protein present in urine. These are the clinical manifestations of glomerulonephritis. I am not going to discuss in detail about this. This can be discussed in your general medicine. And next one is acute rheumatic fever, which is due to the valvular damage due to the antigenic cross reactivity, and also the cytotoxicity of cardiac cells due to this streptococcal pyrogenic exotoxins and streptolysin O. These two toxins are responsible for damage to the cardiac cells and results in acute rheumatic fever. This acute rheumatic fever is manifested in the form of like so many manifestations are there. One is carditis. Here the abnormal thick mitral wall with the fused cardia seen. Here you can see the abnormally thick mitral wall with the fused cardia, and finally it's if it increases its severity, it's this case may results in this form of fibrosis of the mitral wall, which gives like a fish mouth type of thing, and so it's known as fish mouth mitral wall. These Asha bodies are seen in the form of in the cardiac muscle, and they are nothing but the fibrinoid changes in the connective tissues of the heart, where the infiltration of the lymphocytes and plasma cells are seen along with abnormal histiocytes. This finding is microscopic finding, the biopsy of the heart muscle, but under normal circumstances we can't see this one, but these are all produced due to the immune complex formation. Arthritis is most common form of this immune complex mediated disease in the form of rheumatic heart disease, rheumatic fever, where the large joints are involved like knees, ankles, hips and elbows, and they see the heart swollen and red in nature, and also the tenderness is present. If you touch that, if you want to press over this joint, they feel severe pain. Ham's choreothetic movements are seen with this, like abnormal involuntary movements of head, limb and facial muscles are present. This is again due to the involvement of the cells of the central nervous system. Marginatum, this is due to the involvement of the skin or the reaction between the antigens of the skin and antibodies produced by the bacterium. This is erythema marginatum. Here you can see the lesions. These are all the lesions. The pink macular rashes will appear on skin, which may disappear early, and they give like an appearance like smoke rings like appearance on the skin. Nodules produced in the rheumatic heart fever are painless and small, which are mobile subcutaneous nodules. Size ranges from 0.5 to 2 centimeters. So these are all the nodules on the skin. These are all the spinal main protrusions, but they are not the lesions, but these are the lesions. Next, osseous knots is another manifestation where you can see them on finger or tips of the fingers or toes, and they are all highly tender in nature and pea-sized and erythematous nodules. See here the pea-sized erythematous nodules, here also you can see, and here also you can see this kind of lesions. Tests are available to detect the carbohydrate antigen and cell wall. Based on the detection of carbohydrate antigen, we can say to which group they belongs to, because most of the group A streptococci are more pathogenic, and group B streptococci like streptococcus agalactiae also pathogenic. So by identifying the group, we can say that whether they are pathogens or not. And then we have to collect the throat swab and do the gram staining, and it's not much reliable. Why? Because the other forms of streptococci like virulent streptococci are commensals in the throat of normal individuals. So if you do the gram staining there, if you even though you are able to see the gram positive cocci in chains, we can't say that whether they are Streptococcus pyogenes or other species of streptococci. So it's not much reliable, but it can give clue to go further. Then what to do is the throat swab has to be subjected for culture, and always collect two swabs for culturing to avoid the contamination. And once you inoculate on blood agar, on the blood agar you can see the pinpoint grey colored colonies with the beta hemolysis. See here the clear zone of hemolysis you can see around the colony. The clear zone of hemolysis you can see around the colony, which is known as beta hemolysis. If really you collected the contaminated samples, then you have to do the culture on the selective medium like crystal violet blood agar medium, where the crystal violet has to be incorporated in 0.0001%. So in the presence of crystal violet, this bacteria, other bacteria will die, but Streptococcus pyogenes can't die, so it can happily grow on this medium. And another medium is PNF medium, and where the blood agar is incorporated with polymyxin B, neomycin and fusidic acid, which can again inhibit the unwanted bacteria, but won't do any harm to the Streptococcus pyogenes. They can grow happily, so that we can see the growth if at all present in the clinical specimen. Test from the growth or gram staining you have to do, where you can see the gram positive cocci in chains, long chains, and you have to do the catalase test. The catalase test positivity will show with the bubbles or effervescence, but since the test is negative, you can't see any bubbles here. And bacitracin sensitive. So if you keep the bacitracin disc, this is the bacitracin disc and the blood agar, and since they are sensitive to bacitracin, you can see the zone of inhibition around the disc. And another one is PYR test, otherwise known as pyrrolidonyl naphthalomide test, and this is because of the production of pyroglutamyl aminopeptidase enzyme. This bacteria can produce this pyroglutamyl aminopeptidase enzyme, and which acts on the pyrrolidonyl naphthalomide reagent and gives positive results. So here the test is positive here, whereas the test is negative here. So PYR test is positive by Streptococcus pyogenes. Diagnose, other features of this one, diagnostic features of this particular are, one is ASO titer. If the titer is more than 200 international units per ml, that's indicative of acute rheumatic fever or streptococcus sore throat. C-reactive protein, always in any kind of inflammatory process, it's also been increased, and ECG findings have to be seen. And anti-DNase B antibodies and decreased C3 complement levels and RBC Cas in urine and elevated serum urea and creatinine are the diagnostic features of acute glomerular nephritis. Latency of occurrence of all these complications, polyarthritis, carditis and erythema marginatum appear very early, whereas chorea will appear a bit late, and subcutaneous nodules also appear along with the chorea. So this after the infections of 1 to 2 months, all these things will establish in the form of complications in the infected individuals who are not treated properly with the proper antibiotics. Other features for other diagnostic modalities for the diagnosis of rheumatic heart disease is based on Jones criteria. Jones major criteria are carditis and arthritis, chorea, erythema marginatum and subcutaneous nodules are considered as major criteria, and minor criteria are increased ESR and CRP levels and ASO titers and prolonged low grade fever. All are the major as well as minor criteria according to the Jones. So 2 major criteria plus 1 minor criteria, or 1 major criteria with 2 minor criteria will be considered as the diagnosis for rheumatic fever. Jones criteria and also the ECG findings will show the increased prolonged PR interval. See, this is actually the normal PR interval. This is the normal PR interval. But if you see here in this particular case, the prolonged PR interval has been prolonged. So actually, you can see in any this thing ECG. Just you can see here, it will go like this, again it go up, but here if you see this gap or delay in this interval, so this is a prolonged PR interval is seen in ECG, and ESR levels are increased to more than 60 millimeters per hour, CRP more than 3 milligrams per deciliter, and ASO titers more than 400 international units. V or amoxicillin for 14 days has to be given, and aspirin or non-steroidal anti-inflammatory drugs to relieve from arthritis, arthralgia and fever episodes. And sometimes the long-term penicillin treatment is preferred for about 5 to 10 years to prevent the recurrences of acute rheumatic heart disease. And in case of penicillin allergy, we can go for clindamycin or cephalosporins. This is about the streptococci and its complications and other few things about Viridian streptococci. They are commensals in the mouth and upper respiratory tract, which are gram-positive cocci in chains, which produces alpha hemolytic colonies and blood agar, and resistant to optocin disc resistant, and they are insoluble in bile. They are insoluble to the bile, and this is how it differs from the Streptococcus pneumoniae, because the Streptococcus pneumoniae also alpha hemolytic. That is also alpha hemolytic streptococci, and they are also sometimes seen in small chains. So it may get confused sometimes. To avoid it, we can do this optocin test and also the bile solubility test. So these organisms, Viridian streptococci are resistant to optocin, whereas Streptococcus pneumoniae are sensitive to optocin. And these Viridian streptococci are insoluble in bile, but Streptococcus pneumoniae are soluble in bile. And they enters into the blood while the dental procedures and toothbrushing, and they are responsible for the dental plaques and finally leads to the dental caries. And they are also commonly seen, this kind of infections also commonly seen among the neutropenic patients, where the neutrophil levels are low, and also responsible for endocarditis among the people who are having prosthetic heart valve devices. That means the either comorbidities or people implanted with heart valves are more prone for this endocarditis, and by the Streptococcus intermedius and Streptococcus anginosus. And most common cause for subacute bacterial endocarditis cases. So this is how the Viridian streptococci are very important. Group or group D streptococci, the most important species are Streptococcus Enterococcus faecalis, Enterococcus durans, and Enterococcus gallinarum, and Enterococcus faecium. The difference between the other streptococci for this is they arranged in pairs. See, not like in chains, you can see this bacteria in pairs, and they found in GIT and the genital tract, and they have the unique features as far their growth is concerned. They can grow in the presence of 40% bile and the high pH like pH 9.6, and they also can grow in the presence of 6.5% sodium chloride solution and at the high temperature like 45 degrees centigrade. None of them are shown by the other streptococci. On McConkey agar, other streptococci never grow on this McConkey agar, but this Enterococcus group will grow on this McConkey agar and produces tiny pink colored colonies. On blood agar, non-hemolytic colonies are produced. On tellurite blood agar medium, you can see the black colored colonies because they convert the tellurite into the metallic tellurium. So you can see the black colored colonies on tellurite blood agar medium. Bioscreen test will be shown, but this is the bioscreen test. It's a positive, and they are resistant to the optocin and bacitracin. Both are resistant, both optocin and bacitracin resistant. But again, the PYR test is positive and CAMP test is negative. This CAMP test will be shown by Streptococcus agalactiae. I think you might have heard about this in the CNS, where we are talking about Streptococcus agalactiae. So this CAMP test is negative by the enterococci, but PYR test is positive, just like Streptococcus pyogenes. And the spectrum of clinical manifestations produced by enterococcal, nosocomial infections, especially among the ICU patients and people who are on hemodialysis. And intra-abdominal abscesses are produced, followed by the post-operative cases, and wound infections also possible, and secondary infections followed by prolonged antibiotic usage. If you use the antibiotics for longer period, these secondary infections also produced by this enterococcus group of bacteria. To penicillin, remember, and best by using amoxicillin or vancomycin or linezolid in combination with aminoglycosides, in combination with amic acid, that's the aminoglycoside. And drug resistance is mainly due to the plasmid mediated drug resistance is shown by this enterococcus group. This is one among the more dangerous MDR group of organisms, multi-drug resistant bacteria like Staphylococcus aureus, and also the E. coli, Klebsiella, Pseudomonas, and Enterococci. These are all the MDR bacteria. It's, usually we use the word sigla for them. Escape bacteria. Escape bacteria. P stands for, one is for Enterobacteria, group of organisms like E. coli and Klebsiella, Staph aureus, and this, and also the Acinetobacter species, Citrobacter species, and Pseudomonas, and last one is Enterococci. So this is one among these escape bacteria because of their multi-drug resistant nature. Streptococcal infections, including Enterococci and the complications produced by Streptococcus pyogenes. Thank you very much. Have happy learning.